Thank you so much, Lynn, for having me. And it's very nice to speak with people here today. I actually recognize a few faces in the room. So, and the award, by the way, is, I just found out, from the province of Ontario, from the Ministry of Research and Innovation. So it gives me $100,000, actually, not me. But to support getting new students. It's all to be used to be hiring people to run research. It's all for people, for personnel. So that allows me over the next 5 years to continue to take on new students who will be studying BPD and many of the symptoms associated with BPD. So, you know, it's really important that we do research on BPD because, you know, this is where we start to understand how we can refine our treatments, where we can get at what might be causing the disorder and then design interventions and treatments that get at some of these specific causal factors. And I will say thank you to Lynn as well for coming and speaking to my classes. She's come and spoken to my class in psychopathology for a new program that we have at the University of Toronto based at the Scarborough campus, where we have at least half of the class usually of incoming students. It's about 6 students each year that enter this new program in clinical psychology. It's a master's and PhD program, and they learn about mental disorders in the class that I teach at the master's level. And it's a course called psychopathology, and I devote an entire class session to BPD for these people who are going to be going out and becoming psychologists and mental health practitioners. And Lynn actually comes in and speaks about her experiences with the disorder, and it's by far the student's favorite class when Lynn comes in. And so thank you. I'm happy to come and speak to Sashbear. So, all right, so without further ado, let me get into some of the research that we've been doing on the neural basis of emotion dysregulation and some of the related symptoms in BPD. So when we think about what we know, at least today, about factors that might cause and or maintain BPD, it's very similar to what we know about other mental disorders like schizophrenia, bipolar disorder, autism, obsessive compulsive disorder, in that we know that there tends to be a genetic or a biological predisposition to the disorder and the symptoms that are associated with the disorder. And then there's also this kind of give and take with the environment, that there are different experiences that also might contribute to and interact with people's genes and their neurobiology to produce different forms of mental disorder. And so my research tends to focus more on the genetic and biological pieces of the disorder, but I'm also, as you'll see today, the first time I've presented research on how treatments might actually be impacting environmental. So treatments like DBT might actually be impacting the brain and tell us about how the brain is changing through treatment. So this is no different from any other mental disorder. The difference is that BPD has been studied far less frequently, especially from the genetic and biological perspective. We tend to see a lot of research on environmental components, such as early life trauma, and other types of interactions with other people, their relationships, but less on the genetic and the biological. And there is this give and take. You know, some people come to life with just better emotion regulation capacities. We don't know why, you know, but some people are just good at it. I'm sure people in here know people who are just naturally good at this, whereas others, they tend to have more difficulty. And so we know that there might be something that predisposes people to better skills and better emotion regulation. And my research, I hope, will start to help us understand, well, what are some of the genetic and biological predispositions toward less efficient or less effective emotion regulation, and how can we actually intervene? Okay, so emotion dysregulation in BPD, you know, actually is thought to be the core of the disorder. If you look at Marsha Linehan's work, her theory is that the disorder is an emotion regulation disorder, and that the core symptom of the disorder is emotion dysregulation. And my research is, again, trying to understand where this comes from at the level of biology and genetics. And we think that many of the other symptoms that go along with BPD that are actually coming from the emotion dysregulation. So if somebody is very highly emotional and has a difficult time regulating that emotion, They might engage in impulsive behaviors more frequently, often to get that feeling of negative emotion to go away. They might have a hard time having a stable sense of who they are because their emotions are changing so rapidly and so frequently. They might have difficulties relating to other people. That's probably obvious to many people in the room, that if you're in a bad mood and you're having a hard time getting out of that mood, that might make it difficult for you to interact with people in a way that might be effective. And then one aspect of BPD that's often studied and that tends to be better funded as a researcher is the area of self-harming behaviors, physically self-injurious behaviors, and of course, suicide. So when we talk about emotion dysregulation, it's important to remember that this might be kind of the core symptom of the disorder, and it might result in many of the other symptoms that are associated with BPD. So I want to show you really briefly how it is that we tend to, as researchers, study emotion and emotion regulation in BPD and other mental disorders. So first, you can see that we often use some type of a brain scanner in our research. Obviously, if we're going to be studying neural activation, we're talking about using these advanced technologies that help us to inspect and probe these neural systems in the brain. So one of the most common types of brain scans that you'll see in research on BPD is an MRI. I'm sure if somebody's had an MRI before, you hear all these banging sounds, and in a functional MRI, where you're actually measuring the activation in the brain, what you can do is present pictures to people in the MRI, usually using this kind of mirror device to be able to finally get that image into the center of the magnet. And we'll show pictures like emotional faces, like this one, or all sorts of different things. There have been all kinds of studies on BPD looking at emotions and emotion regulation. In Germany, we see research where they'll have people talk about abandonment histories, times when people have been abandoned. They'll write these things down and then replay them to the people in the scanner while their brains are being imaged. So in the research that we do, we need to somehow use some type of probe, okay, that will activate those emotion systems, and then examine that information that's happening at the level of the brain using our brain imaging techniques. If anybody's been in my research here, which I have a feeling that at least one or two people have been, at the University of Toronto Scarborough, where we do a lot of our research on families, we actually use a different brain imaging device. It doesn't use magnets, as in an MRI, but instead we use infrared light, actually using light to see how it's bouncing off of the blood in the brain and examining changes in light intensity to tell us about what parts of the brain are being activated. So there are all sorts of different, really new and interesting ways that we can measure brain activity. And so we do this wonderful thing, present them with pictures of faces. And in the research that I've done and published just last year, which I guess almost 2 years ago now, is research where we put all of this information together that's ever been done. Research on brain imaging in BPD and how people with BPD, how their brains are lighting up when they're just shown pictures of emotional faces. That's typically the way that we study emotion and how the brain regions involved in emotion regulation are invoked. But there have also been other things I've talked about, looking at the brain while you're reading a history of abandonment to the person. So I've put all of this research together, and up until this point, this is the most definitive study that we have on how the brains of people with BPD are activating differently from people without BPD when they're processing, viewing images that are showing some type of a negative emotion. It tends to be pretty similar across negative emotions. So these are things like sad faces, angry faces, disgusted faces. So what we find is that people with BPD tend to have more activation in certain regions of the brain. One region of the brain that you'll see here is the insular cortex, or the insula. That, interestingly, was a part of the brain that nobody really talked about in prior research, but we now know is very much involved in representing how intensely somebody feels an emotion. I've heard this before, not just from people with BPD, but people with bipolar disorder, who will tell me that they feel that they experience emotions inside more intensely than other people who don't have BPD. That their experience of an emotion is probably more intense than the average person out there. And so this information here, that the part of the brain that's involved in representing how intensely somebody feels an emotion, the fact that it's overactive might be an indication that somebody is actually, might be a neural basis, to validate and justify why it is that somebody with BPD might be experiencing an emotion more intensely. So this was kind of an interesting finding, because most people, when they talk about brain imaging and BPD, we hear about the amygdala. It's this part of the brain that's deep in the brain that's associated with emotions as well. It's hard to image, actually, compared to the insula when it comes to getting at that part of the brain, getting good signal from that part of the brain. And that part of the brain probably does activate more so. It didn't come up in our research as being an important area where there's increased activation, but at least based on this research, we found this to be more compelling finding. A more interesting and statistically significant finding, that it's a part of the brain that's involved in subjective perceptions of the intensity of emotions. Now, we also found greater activity in a part of the brain called the posterior cingulate cortex. The name doesn't need to convey too much information right now, but this is a part of the brain that's involved in how people perceive themselves, okay? It's actually activated more when somebody is just kind of reflecting on their own personal attributes and characteristics. So we start to see here how parts of the brain that are involved in how intensely we feel emotion and how we kind of think about ourselves, a part of the brain that's involved in reflecting on ourselves, these two areas of the brain are overactive in people with BPD. So you can maybe start to see how it is that emotion dysregulation might impact parts of the brain that are not just involved in emotion, but potentially even involved in how somebody perceives themselves. So this is the side of where we're looking at, well, what's red, what's showing more activation in people with BPD. On the other hand, we saw less activation in certain regions of the brain, and I was anticipating that they would be closer to the front of the brain. That's kind of the newer part of the brain, evolutionarily speaking, the part of the brain that's involved in trying to control emotional experiences, so trying to dampen activity in these other regions of the brain that are involved in generating emotion. And so what I found was that the part of the brain involved, or the parts of the brain involved in regulating emotions, especially effortful regulating of emotions, like the skills you might learn in DBT, where you're effortfully trying to regulate an emotion, versus the parts of the brain that automatically kick in when you feel an emotion and they're trying to regulate it. But these effortful parts, housed in the dorsolateral prefrontal cortex and the frontal lobe. Frontal lobes are actually quite large. They come all the way down to here about, so it's a very large region of the brain. These are underactive, which again provides us with this potential neural basis for what we know as potentially being the emotion regulation center, the part of the brain that puts the brakes on the emotional experience. And then we also found, here's my little pop-up saying that there might be less effective emotion regulation capacity. And then this part of the brain called the subgenual anterior cingulate cortex, which is very much involved in the stress response. Okay, how it is that the brain is responsive when somebody's experiencing a stressful situation, like maybe looking at some of these emotions that I showed you, this part of the brain is less active and might reflect this limited ability to process, recruit resources associated with stressful situations. So this part of the brain is actually quite interesting, because in research on depression, the research suggests that this part of the brain is actually overactive in depression. And sometimes people, in the past, less so as the word is getting out that BPD is different from depression, but people have said that, BPD, how is it really different from depression when we're looking at our brain imaging findings? Well, this is one area that we can almost call potentially a biological marker for BPD, because it's actually underactive. And in people with severe depression, intractable depression, it's actually overactive. And they'll go into the brain and actually install deep brain stimulation treatments to be able to affect activity in that region. So some of the research that I'm hoping to get funded in the future is to be able to probe this region in greater detail to see if this might be a biological marker that is unique for BPD. But this is still something that are speculations. Okay, so when we talk about how these parts of the brain might be affected in BPD, those involved in emotion regulation, we think about, okay, well, how can we use this information to maybe have a beneficial effect on somebody's treatment? So we know that treatment of emotion regulation in BPD, one of the most common treatments used and one of the most effective treatments for emotion dysregulation in BPD is DBT, and we already heard a little bit about it earlier. So it's among the most effective treatments for BPD. It's especially effective in reducing the emotion dysregulation symptoms, impulsive behaviors, self-injurious behaviors, reducing hospital readmissions. Until now, though, we haven't known very much about how DBT might actually change the brains of people as they go through treatment. We often think about brains changing and brain activation changing as a result of a biological treatment, like a medication. But our brains really are what produce our behaviors, okay? And if our behavior is changing through something that's even if the treatment itself isn't administering a biological agent, our brains should be changing. And we know this with other mental disorders, especially anxiety disorders, which have been studied a great deal from this perspective, and depression. But BPD we know less about. There was one study in the past that only involved 6 people, and we saw some preliminary changes in frontal parts of the brain. So what I did is I ran a study, and it's the first one that's ever really involved such a large group of people. And what I did is I was trying to focus on impulsive behaviors, kind of what I think of as an outgrowth of the emotion dysregulation in BPD. I won't go into the details of how it is that we're measuring impulsivity, but I'll say it's a very simple task, okay, where somebody has to press a button when they see a green circle and don't press the button when you see a red circle. And what this does is it really activates those frontal parts of the brain that are involved in controlling emotions and in controlling behaviors. And we use this in particular at U of T Scarborough because the brain imaging device that we use is focusing entirely on the prefrontal cortex. And if we think about how this information might be used, okay, in the future, brain imaging information, we have to be thinking about the cost effectiveness of these tools. MRIs, an MRI scan to book an hour of time costs about $500 an hour, okay? For the type of technology that's using infrared light that we have in my laboratory at U of T Scarborough, it actually costs us about $25,000 to buy the system, and then it works for the rest of your life. It just uses electricity, okay? So what we can do is potentially, if we can identify parts of the brain that might be changing through treatment using a cheap technology, and maybe see whether we can scan somebody's brain before they even get into treatment and see if there's something about that brain activation that tells us about who's going to respond better to DBT versus those who don't, then maybe we can kind of reduce the wait list and target those people who, based on a simple free brain scan, might benefit more from the treatment or from a different treatment. So what we did was we looked at 31 people with BPD, and this is completely new. Nobody's ever seen this before. It's 31 people with BPD who went through DBT at CAMH. They went through the full 1-year treatment at CAMH in the regular clinic there, BPD clinic. And this is a study I did in conjunction with Shelley McMain and with Paul Links, who's now the chair of psychiatry at Western University. And what we did is we scanned these people's brains using our light imaging technology before they started DBT at CAMH, and then again after they completed 6 months of DBT. This is a study that was funded by the American Foundation for Suicide Prevention, where we were specifically interested in people with BPD who were quite impulsive, and in particular their impulsivity came out as frequent self-harm, almost pretty much on a weekly basis for the 6 months prior to coming into treatment. So what we did was we asked people to do the simple task that asked them to control their behavior. It seems simple. And then see how the brain is activating before they start treatment, and then what happens after treatment. I don't have information just yet about which parts of the brain are predicting who does better in treatment. That's something I'll be looking at in the next few weeks. So If we look at before they start treatment, when they're just simply asked to not press a button when they see a red circle, and the parts of the brain that are involved in putting on the brakes, as I showed you in my other study with emotion regulation, which tend to be on the left and right side of the frontal lobe, these parts of the brain are actually showing less activation, okay, than when they're simply at rest. So there's actually the parts of the brain that should be lighting up are actually not even just not lighting up, they're actually getting lower. They're showing less activation in those regions, okay? So this is before they begin therapy. And then after therapy, you can see that the brain is actually the frontal parts of the brain when they're doing the exact same task and have to control their behaviors. But by this point, their symptoms have improved, their self-harming behaviors for everyone except for one person improved significantly after 6 months of treatment. When they're asked to control their behavior, you see this huge lighting up of activation in the brain. So what you can see here for the first time, and this is based on 21 people in the end, because about a third of our sample dropped out of treatment and didn't complete treatment. What happened is, you see that in people who at least completed treatment, which is a third of our sample, they actually went through and there are parts of the brain that should be recruited for behavioral control are actually online again. And so this is the first study to actually really look at this, especially with impulse control. And another thing we're looking at, which is probably not going to be a surprise to you, I do have the results on this, that the people who ended up dropping out of treatment are actually showing even less activation in these frontal parts of the brain at baseline than even everybody else in the group. So there might be something even about the most severe people, the people who are not going to end up benefiting from treatment, who end up looking different in terms of how their brains are activating. Yeah, I see a question.
I find it very enlightening if you could just define a bit the behaviors, impulse control, what kinds of behaviors they were controlling.
So yeah, so all it was stopping themselves from pressing a button.
Oh.
Very, very
That was
simple.
simply the experimental.
Yeah, experimental.
Not
Yeah.
oh.
But we do measure their symptoms overall in terms of BPD symptoms, other types of impulsive symptoms, and all these things really get better through treatment, like hugely, at least the people who complete the treatment.
Well, that's what I was wondering, what the connection was.
Yeah, so the connection is still something we're looking at, but what we're assuming is that it'll be associated with improved impulsive behaviors that they're reporting have improved. But we haven't looked at that just yet. This is just the brain activation right now. Yeah, I wanted to give you something new, hot off the press in this presentation. Is there one other question? Yeah.
Yeah, just a quick question. I'm not sure if you mentioned, was this adult patients?
So yeah, these were all adults,
These
at
are
least
all
18 years old.
And would you expect similar results in adolescents?
It's a good question. We don't know yet. We don't know yet. I think there's very little research on brain functioning in adolescence. It tends to look somewhat similar, but we think that in patients who are a little bit older, but I mean like 18 and older, there might be other things that are changing how the brain is functioning, like medications that people are taking. Maybe if people have attempted suicide and they survived, but they've had brain injuries, or there have been just subtle changes in how much oxygen went to their brain, and there are all sorts of things that with the experience of having the disorder might actually change how the brain is functioning compared to younger people who haven't had a lot of these other potential experiences that could be also changing the brain. So we don't know just yet, but it's a really good question. Yeah?
When you're saying adults, are you talking in between 18 to 25 mainly?
No, it's 18 to about 45.
Is there any difference between the 18 to 25 to the 25 to 45?
We haven't looked at any of that yet, it's a good question, but I think that the older patients in general, especially the ones in this research, have tended to be more severely ill, meaning harming themselves more often, have not gotten treatment for their disorder for a very long time, or appropriate treatment for a very long time. So yeah, and even just talking to these people, they're not just my research participants, I talk to them and I hear about their experiences, and I can tell you that those who tend to be more in their 40s, I would say we may have had 2 or 3 people in their 50s, and yeah, it's a very different experience for people who are older versus younger. I think, yeah, people would agree with that. Yeah.
Did you control for whether the subjects were on or off medication?
So these people were almost all on some type of medication. So we don't really feel comfortable asking them to stop taking medication for this research. So I should say this research is actually a pilot study, a preliminary study. The purpose is to go and conduct a much larger scale study, looking at the same types of things, but with more controls built in. So yeah, so what this tells us at least is that the brain seems to be changing, and the next step is, in our analyses, is to look at, well, what's predicting changes in treatment.
Were the medications prescribed for BPD? Because as far as I know, there is none.
So the medications that tend to be prescribed tend to be those that are more trying to control depression, you know, trying to keep anxiety under control.
Wouldn't they have the opposite?
It could. We don't really know what impact a lot of these medications have on the brain. We measure actually whether their medications have changed from the time they came in to later. We haven't gone into any of this information, but it's a great preparation as I write up the manuscript for this, because I need to address all of these things, because I will have scientists who will say, well, what about this and what about that, and these are the questions they're gonna have, so, yeah.
Do you have any comparisons 6 months post-therapy?
So we actually implemented a 1-year follow-up as well. So after they completed the 1 year, we haven't finished that yet, but the reason we added that, and it relates to a study that's recently been funded at CAMH in the BPD clinic, is that we found that many people at 6 months, even though they might have been improving to some extent, they didn't feel like they were getting that much better. And then, not everybody, but those who stayed in the study and completed and went to 1 year, we found that people, at least subjectively, said that I feel now I'm getting what I'm doing. Like the first 6 months I didn't really get exactly what I was doing in treatment. Not everybody, it was just a subset. So we thought we should follow this up over the full year. So we don't have the results of that yet, but we are doing that. Yeah, good question. Yeah.
During the 6 months of DBT treatment that they were receiving, how intensive was it? How was it daily?
So it's a what? Yeah, good question. So it's the standard DBT. So they have the individual treatment, and then they also have the group, the skills group. So the standard treatment that's offered through the BPD clinic. So it is more intense. The original proposal for this study was to do 20 weeks of skills group, and the people who approved this research said that's not enough. We want a more intense treatment. Okay, so what I'm doing next, and this is something that was funded by the Brain and Behavior Research Foundation in the United States, is a study that probably won't be starting for at least several more months, is looking at a new treatment that is only available in a few centers in the entire world. I think one in Australia, maybe Denmark, and CAMH. And what we've got is this treatment called magnetic seizure therapy, or MST. It's almost like electroconvulsive therapy, okay, which we kind of don't really talk too much about, because research actually suggests that it's not helpful for BPD. And I've seen people in my research who have gone through this as well, and they don't even, remember, large portions of their lives when they're going through the treatment, because electroconvulsive therapy ends up, affecting the whole brain, and the parts of the brain that are involved in memory and really attention and concentration, they're really all affected because your whole brain is basically receiving an electrical current. What's happening now is advances in this type of treatment where we're able to use magnets, and I'm not an expert in this, okay? This is the expert right here, Dr. Dialectical at CAMH. Where you can use magnets to target where the electricity is going to somebody's brain. It may sound, extreme, but this is being used all of the time in lots of different centers throughout Toronto and around the world, where we're using an invasive kind of treatment where we're stimulating the brain in certain regions based on the types of research that I've already showed you, and hoping that changing activity in those regions might have some type of improvement on symptoms. So this is being done, there are studies right now going on looking at OCD, schizophrenia, depression, I think even dementia, but don't quote me on it. And so BPD is one of those disorders where I think we need to study this and see if this might be effective for some of the symptoms of the disorder, especially given that the treatment is specifically supposed to target the prefrontal cortex, which is exactly what I've shown you up until today, throughout today's presentation, that this is the area where we see differences in brain activation for people with BPD. So this study will actually be potentially giving us, information about whether this disorder is, sorry, this treatment is effective for some of the symptoms of BPD, especially things like depression and emotion regulation. So this is the future, at least of what we're doing, and because research is so critical to advancing, the field, and not just on BPD, but on emotion regulation more generally. It's important for us to do research, and for people to get involved in research. And so this is my quick plug here to say that I'm sure there are people who have already been involved in my research in this room, and there may be people who didn't qualify for some of the research. But if you haven't already, we're continuing to do one study that will be ending in September, where we're looking at families of people with BPD to determine whether we can find biological markers, like the ones I talked about today, in people who are family members, so not somebody with BPD, but somebody who doesn't have BPD in a family, to see if they still show even a subtle difference in how their brain activates, and if that may tell us some information about whether that part of the brain is affected in the disorder, and whether it's transmitted across family members, potentially through genetics. So this study is funded by the Canadian Institutes of Health Research and will be ending in September. But regardless, what I'd like you to do is, if you're willing, give us a call if you're somebody who might want to participate in this study. That's the phone number there. And then we do have a research registry. It's a place where you can just go online and put your name and contact information, and we'll contact you when there's a study that might be available for you to participate in. And it's really thanks to people like Lynn, who have really put the word out there, and others, Julie's in the room somewhere, who helped us to really get the word out about these studies, because really Toronto, and especially U of T Scarborough, we're gaining a lot of expertise and really a reputation of research in BPD, and it's really by you participating in research that we're really able to find new things that will hopefully treat people with the disorder. So that's everything for me today.